Thank you, Dr. Nihal, for this presentation. Thank you, Dr. Hassan and Dr. Medhat, Dr. Salah, and the group of IFRI, Dr. Ashraf, for inviting me to this presentation. I'll talk about artificial oocyte activation in general and strontium chloride mainly based on our publication in Human Reproduction 2018. Before the start, is one thing to that we need to talk is IVF and XC are effective treatment. So we will talk about an add-on treatment or extra treatment, but not for an invention of such treatment. However, despite the advances with XC, there remain around 3 to 5% of XC cycle will end up with fertilization failure. Fertilization, by definition, is a sequence of biological process initiated by entry of spermatozoon into a natural oocyte, onto a mature oocyte, followed by formation of pronuclei. Successful fertilization requires oocyte activation, which depend on interaction between the gametes. Before fertilization, mammalian oocytes remain arrested at the metaphase 2. A phenomena require elevation before subsequent embryogenesis may proceed. This meiotic arrest is released through a series of event termed oocyte activation, including cortical granuloexocytosis, second polar body emission, pronuclear formation, and subsequent division. In normal fertilization, the phospholipase C zeta of a fertilizing spermatozoon produce inositol triphosphate within the oocyte, which interact with the receptors in the endoplasmic reticulum, releasing or causing calcium oscillation to trigger the oocyte activation. The oocyte also contribute to the activation events via identified and other unidentified factors, with the precise mechanism underlying the oocyte activation remain not fully understood so far. Here is the major points that we need to know. The calcium wave intense duration repetition are likely responsible for the effective activation. So whether a single or multiple calcium waves are the better initiator. In this photo, the upper is a single wave, and in the lowest half of the photo is multiple waves. In animal models, the duration, amplitude, and frequency of calcium affect the normal oocyte activation and embryo development. Okay. Whenever the physiological mechanism is impaired, the artificial oocyte activation can rescue the fertilization and the downstream event. For the artificial oocyte activation, there is mechanical, electrical, chemical activation to do so. Mechanical activation is accomplished by vigorous aspiration of cytoplasm during the XC, which result in major calcium increase. The mechanical protocol can overcome both sperm-related and oocyte-related activation deficiency. The electrostimulation alters the activation potential of ion channels to the ooplasmic membrane. So the application of electrical pulses created ionic channel to the oocyte, allowing for calcium entry from the surrounding medium. To date, the chemical activation is the most commonly used and most efficient oocyte activation approach in practice. Calcimycin, ionomycin, pyromycin increase membrane permeability to extracellular calcium and induce single prolonged calcium wave. As I said, there is a single calcium wave can be produced or multiple calcium wave can be produced artificially. Those what's so called in the market is calcium ionophore, either calcimycin, ionomycin, pyromycin, or whatever. There is also another factors called strontium chloride. Strontium chloride, or maybe also anhydrous alcohol, can release a calcium from the endoplasmic reticulum in waves, in pulsatile waves. This factor is different in in their mechanism rather than the calcium ionophore. The calcium ionophore is an enforcement of a calcium wave from the surrounding medium, while the strontium chloride is the initiation of the endoplasmic reticulum of the oocyte to release its own calcium, no calcium from the surrounding. Two meta-analyses are available with contradictory conclusion regarding the artificial oocyte activation for improving embryological and clinical outcome with cycle with fertilization failure. However, that analyses include retrospective studies, historical comparison, or relatively underpowered studies. Most of the studies have only examined calcimycin artificial oocyte activation, although strontium chloride has shown potential for artificial oocyte activation in other reports. No comparative randomized controlled trial evaluated the relative effectiveness of calcimycin and strontium chloride compared with XC alone. Despite the lack of clear evidence, the procedure has been continued to be promoted. We decided to take part addressing this issue, and we come up with a publication 2018 in Human Reproduction comparing the calcium ionophore versus the strontium chloride versus the XC alone in randomized prospective comparison. We included infertile couple who were undergoing XC cycle for previous low fertilization, which was defined as lower than 30% in previous cycle, but normal semen parameter. This group was low fertilization failure despite the normal semen parameter according to the WHO criteria. And a second group was XC cycle undergoing their first attempt due to male factor infertility with abnormal sperm morphology. We classified previous cycle of low fertilization as unexplained low fertilization or as low fertilization associated with impaired oocyte morphology, but within normal sperm parameter. The male factor infertility cycle were either frozen cycle sperm, surgically retrieved sperm, or ejaculate sperm containing lower than 10 million spermatozoa per milli undergoing their first XC attempt with 100% abnormal sperm morphology, including globospermia in some cycle. This is a flow chart of the study we did between April 2015 to January 2016, but with a screening period of close to 18 months before recruitment for these cycles, and then inviting some of them to take part in trial regarding and methodologies that can help them improving their fertility, which was intended to make the duration of this study as short as possible to counteract for any possible culture condition impact on the trial or manipulation of stimulation protocols or whatever. So we were tight in this point for this trial. This trial included 115 in the calcimycin group or the calcium ionophore group, and 113 group in women in the strontium chloride group and 115 women in the traditional XC group. Our intervention were the use of strontium chloride, as I said, or calcimicin or XC alone. The results of the cycle baseline characteristics were comparable, except here for the number of mature oocyte, which is incorrectly reported. Unfortunately, in our analysis of the data, we find that this 13 is 12, and this 12 is 11, and this 11 is 10.5, but with no effect on the overall conclusion. But it's just a reanalysis of the data. We are doing this every now and then to reanalyze our studies data to find if actually, when we advance in statistical methodologies, then we reanalyze our data again to see how we reported it correctly or not. And for this study, we reported it correctly, except for these points, and these points found not affecting the overall conclusion of the study. The intention to treat analysis of this study for the embryo development revealed that regardless of cleavage rate, strontium chloride significantly improved the fertilization rate and its consequence to blastocyst and cryopreservation rate. For cycle of previous impaired fertilization but normal semen parameter, strontium chloride was found to improve embryo development more effectively than calcimicin compared with XC alone. For cycle with male factor infertility related to abnormal sperm morphology, calcimicin was more effective than strontium chloride when both compared to XC alone. For strontium chloride and calcimicin regarding the clinical outcome, both improved the live birth rate compared to XC alone. Among couple with previous low fertilization, we found strontium chloride activation significantly improves the rate of live birth and live birth implantation compared with XC alone, whereas calcimicin artificial oocyte activation and XC alone were comparable. Calcimicin might be less effective than strontium chloride because it induces a single calcium wave that is not converted into oscillation, which could explain why calcimicin artificial oocyte activation and XC alone were comparable in this subgroup. Neither sperm entry nor XC appeared sufficient to initiate oocyte activation, which is likely related to the activation defect of the oocyte. So calcimicin artificial oocyte activation appear to be not beneficial for XC cycle with previous impaired fertilization, but normal semen parameter. Among couples with male factor infertility but abnormal sperm morphology, calcimicin activation significantly improved the rate of live birth and the live birth implantation, whereas strontium chloride activation and the XC alone were comparable. It is likely that when the problem results from male factor infertility, calcium oscillation machinery is functional in the oocyte, but it has insufficient stimulation by the XC alone with the affected sperm. Calcimicin activation provide additional calcium entry from the surrounding medium, boosting the initiation of calcium oscillation. In this situation, strontium chloride may have less effect because the defect is not with the calcium oscillation machinery itself, but just the initiation of the oscillation. Overall, comparing strontium chloride with calcimicin artificial oocyte activation resulted in comparable clinical outcome. For male factor subgroup comparing strontium chloride with calcimycin result in similar outcome. For previous impaired fertilization cycle, strontium chloride was superior to calcimycin activation, resulting in higher rate of live births and live birth implantation. This study has some strengths and weaknesses. The study represents the first RCT with an appropriate sample size to compare strontium chloride with calcimycin for artificial oocyte activation. Although clinical pregnancy was a primary outcome, we assessed the ongoing and live birth rate of the study. These findings provide insights into the relative suitability of strontium chloride and calcimycin for artificial oocyte activation for particular causes of infertility, which can improve the outcome for subgroup of patients who experience poor outcome of ICSI. The open label trial design might have introduced some bias, although randomization at least partly addressed this possibility of this study. The study didn't include a longitudinal follow-up period, so further evidence regarding the safety of artificial oocyte activation is still required. The study included couples with different indication for ICSI rather than focusing on a single subgroup, but the post-hoc analyses were performed to determine the particular effect of artificial oocyte activation in this subgroup. ICSI followed by artificial oocyte activation with strontium chloride or calcimycin was associated with significantly better embryological and clinical outcome than ICSI alone. Calcimycin artificial oocyte activation appear effective in overcome defects related to abnormal sperm function. Strontium chloride artificial oocyte activation appear to improve outcome for ICSI cycle characterized by previous implantation failure. The long-term safety and transgenerational effect of artificial oocyte activation are thus far unknown, so that we do not recommend this treatment to the general ICSI population. Instead, we recommend that more studies are performed to further elucidate the mechanisms that underlie this finding, in particular those related to the strontium chloride activation. It is also recommended that multi-center artificial oocyte activation trial should be conducted to identifying the cumulative live birth rate as a primary outcome, including the offspring health as also a primary outcome. Until these studies are conducted, artificial oocyte activation should be used cautiously, and here we underline this, should be used cautiously, not routinely, as some of the centers overseas doing this. Artificial oocyte activation should be used cautiously, and the advantages and disadvantages regarding its use should be weighed in each case. The decision in every single procedure is to choose wisely. Choosing wisely should be our concept in our life. So, Adama, I was the primary investigator of this study. I would like to comment that this was the first study with the maximum sample size that I know addressing this issue. But when we have to take a substantial, we need to take a substantial conclusion, this sample size is not sufficient. The sample size of 115 per arm is not sufficient. So to have a substantial conclusion on this issue, you need at least to recruit around 2,200 participants in the 3-arm prospectively, so you can have your conclusion substantial. So as the investigator of this study, I could entitle it as a pilot proof of concept trial. And based on this, we have to choose wisely which patient will require which agent for the artificial oocyte activation, as we should know and we should believe in IVF or in every medical category in the rule or rule one in our practice is to do no harm. And thank you very much.
Thank you very much, Dr. Mohamed Fawzy, for such informative and to the target presentation. Please let me ask you a question. As we all know, EXI procedure escape earlier steps included in IVF procedures, such as the ability of sperm to penetrate the cumulus and bind to oocyte. My question is, how can we apply protocol of oocyte activation in case of IVF?
For this, I have no answer about this, but there is some point to think altogether, all about it. Can we add some agent which is proven safe to be incubated with the oocyte from 1 to 4 hours as a strontium chloride to a medium of IVF, and just include this for with the sperm for 1 or 2 hours, and then move to another medium? It is an idea to be tested, either it will work or not. But to apply artificial oocyte activation on IVF, we can apply what is called rescue activation. It can be done, but to the best of my knowledge, it will not work if you add an activating material after the window of fertilization of oocyte has been ended.
Do you mean by rescue activation, injecting the oocyte with sperm with a minimum amount of strontium chloride into the oocyte at the time of injection?
No. You asked me about if there is a
In
possibility
IVF, yes.
to implement artificial oocyte activation in IVF rather than ICSI. In
Yes.
IVF, there is no possibility to implement artificial oocyte activation published, but an idea, theoretical idea, we can include strontium chloride as an activating material for the first 1 to 4 hours, as it was proven safe that it can be around the oocyte from 1 hour to 4 hours during the IVF procedure, and then after 3 hours or after 2 hour or 2 hour and a half from incubating the sperm with the oocyte, then we wash and take this oocyte into another fresh medium, taking into consideration the recent recommendation, or the recommendation that no need to incubate the sperm for 1 day, just 1 to 4 hours is enough. So we can use this as an idea. This is just theoretical idea. I don't know if anyone implemented this, just come to my mind now. What I meant by rescue activation, that if the sperm failed to activate the oocyte in a traditional IVF, then we will do some centers do rescue ICSI after some times, which I believe it will not work well. But if this is the case, we can add to this procedure one type of artificial oocyte activation, which is much to be done, by the way. Strontium chloride is a one way, calcimicin is another way, and there is also a protocol regarding ionomycin, which is more superior to calcimicin, or the traditional calcium ionophore used. Ionomycin has higher efficiency on that, and we have studies that not published yet that we are using ionomycin as a droplet of ICSI. In the ICSI during the ICSI procedure, the medium droplet contain ionomycin during the injection procedure, and also we inject some picogram of calcium chloride during inside the oocyte during this procedure, and this for extremely difficult cases to be fertilized, or that not responding to any other protocol, and we have a promising results with this protocol.
Was published in two now.
Not yet.
Not yet. But
Okay.
some study, one study is published in 2019 and talked about a protocol of two times of exposure of calcium activation. First exposure by injecting sperm with calcium chloride inside the oocyte. After 30 minutes, expose the injected oocytes in calciumycin or calcium ionophore.
Yeah, this is in Belgium by Bojorn
Yes,
Hendricks
yes,
group. They are doing this mainly on immature oocytes or
yes.
mice oocytes, and for humans they are doing this cautiously, but they didn't compare their protocol with their pair. We compared this with some changes rather than they are doing it. They are doing it as an immediate activation rather than including this in the droplet of ICSI
Yes.
for 7 to 10 minutes in ionomycin, and then we'll wait for 30 minutes and we will do another cycle of ionomycin. And they believe, by the way, as we found, ionomycin is superior to calcimycin or whatever. And I can certainly assure you, in my hand, on our hand, ionomycin will be, if it was proven safe, a rescue treatment for much of fertilization failures that not responding to other activation materials.
So, Dr. Fawzi, as you mentioned, the necessity of oocyte activation for fertilization. Is it necessary for development? I mean, does the assisted oocyte activation has a role on development from cleavage stage to blastocyst stage? And if it has to, we have to expose embryos of previous trials with embryos arrested on day 3 and they can't develop to day 5 and they make a blastocyst. In a second trial, does we have to do artificial activation on day 3 in addition after injection?
Okay, let's have a baseline. First, a parthenogenetic division of embryo is found. There is
Yes.
something called parthenogenetic division. So agents that can help oocyte or embryo or zygote to develop further, even if we consider it as a fake fertilization, is found. And it's much of agents. There is a report here from Egypt, I think, from Dr. Yasmin Magdi and Dr. Ihab Darwish regarding the cycles that stopped. 4 cycle, I think, their preliminary report published in RBM Online 3 to 4 years ago, I think, as I could remember. They found that cycle of blockage at 2PN stage will benefit from calcium they have found them benefit from calcimycin activation. Uh, this is a proof of concept was reported. Theoretically, factors like strontium chloride or anhydrous alcohol, I'm not talking about strontium chloride per se as a name, as we compared strontium chloride, but there is much agent to work like strontium chloride with the same mechanism. It induced multiple waves of calcium, started from the time of fertilization until the time of pronuclear stage formation or even further. So these multiple waves of calcium may have a role on embryo development. As we found, the embryo development is superior in this arm. Whether we can do this for embryo development or develop the embryos, not it is untested so far, but there is an animal study published for the activation of I said there is a report from Egypt published 4 years ago by Dr. Ihab Osman and Dr. Yasmin Magdi. They are talking about improving the cycles that had arrested embryo development at pronuclear stage, and when they did artificial oocyte activation for these 4 cases, I think they developed further, and some of them, one of them or two, get reached the pregnancy, which is was a proof of concept at the time when published to RBM Online. As I said, that the parcinogenic division or parcinogenic activation is found. So, and for human to put an embryo in strontium chloride or in calcimicin or in whatever agent, it is so far unjustified and not tested, and its safety is has much of concerns, as the artificial oocyte activation itself per se has much of concern so far. So if we moved further to implement it for embryo that is developed abnormally in previous trial, it is still unjustified to the best of my knowledge. But for the theoretical and for the research and for the point to be further evaluated, uh, there is an animal study published on Cell Journal 2 years ago that they have done parcinogenic division of unfertilized oocyte. They put unfertilized or non-injected with sperm oocyte into strontium chloride for 2.5 hours, and they found this animal study, a mice study, has developed into two plastomere, and then they have taken one plastomeres and then injected the sperm into the plastomeres that is developed. One plastomere with one sperm after parcinogenic division developed into a complete blastocyst, and they have mice born with this procedure. So theoretically, uh, when and how strontium chloride or calcimicin can be used, it is a matter of further research, but no one so far can justify that we can use artificial oocyte activation at any embryo stage to the best of my knowledge.
Okay. Dr. Fawzi, I have a comment, a last comment. Artificial oocyte activation may help to give live birth, but it can't prevent mutation transmission if the problem in the mutation of phospholipase zeta. It may be transmitted to offspring.
Yes.
Last issue conference, SAIG of interest group of andrology, talking about gene editing by CRISPR to prevent infertile offspring. What's your opinion in this issue?
Germline editing is so far for under research and not to be applied for human. It is there is gene editing has much to add when it is officially agreed for clinical application. It will help those for azoospermia. It will help those of not producing oocyte, or it helps those who produce only immature oocyte, and those will have only spermatocyte in their testis with no further stages of sperm. CRISPR and its new baseline editors and its new agent after that working, not only to edit the genome, but also to edit the epigenome, will be a paradigm shifting and a game changer technology in the reproductive biology. But to establish this, there is no uh, agreement to use germline editing in any human.
So
This
we
is
have
not, yeah,
so
not,
we
not
have to analyze the cause of oocyte deficiency, activation oocyte deficiency before starting the treatment.
okay.
What is the cause of the problem?
I,
Uh,
I agree with you, Dr. Nihal, but the issue need to be with a clear indentation. To diagnose or to use artificial oocyte activation, we are not so far, we are not making any editing in the genome. Germline editing by the use of any further technique will be transgenerational effect, which is a very dangerous. So it is not so far agreed to be used. And the one used the germline editing in China has been in the jail now. They didn't agree about what he did, and they refused what he did. And what he did is he have a two baby girl porn after germline editing that their mother and their father, I don't remember the exact, they have HIV, have AIDS, and they would and he would like to protect them from achieving AIDS, and he did a gene editing that was proven responsible to prevent them from contracting the HIV virus, and he did that for the germline editing, and two girl born after this, and he was fired by anyone in the scientific community. He was fired by a long article on the Nature magazine, and his professor in USA said, "I don't know him, and I don't want to even see him." So everyone left him to go to the hell. So this point so far is still under investigation. Of course, we can use it on animal oocyte or for clinic or with human oocytes that was not for clinical application. So those donated for research, or some immature oocytes that will not be used in any clinical issue, that M1 that will not move forward to M2 or GV. You can use what you want to use
Yes.
according to the ethical standards in this area.